Hey guys, my name is Dr. Daniel Choi. I'm an orthopedic spine surgeon. This is a day in the life. Part of my job is not just being a spine surgeon, it's actually being a dad. My wife is actually a physician too, so part of my morning is taking care of some of these household duties like tidying up, making sure all the meal prep for the baby's been done. We share all these duties and we get the work done together. So we're always thinking about how to make ourselves more efficient, how to support each other and make sure that we take care of our daughter and also be successful in our careers. Part of what we do is we meal prep on the weekends for Alicia's meals, and it's kind of funny because when I meal prep, I'm like, wow, I'm cooking so healthy for her. I would never put any kind of garbage in Alicia's system, never feed her McDonald's or anything like that, even though I kind of eat it myself. We want to make the healthiest foods for her. This is a pea and broccoli and cheese soup, all organic. And then this is chicken meatballs with zucchini, peppers, and carrots mixed in so she can, we're hiding the veggies. And this was all, I spent Sunday doing this, and it gives me happiness to know that I'm gonna go to work and Alicia's gonna eat well. And so that's part of the duties of being a doctor dad. We are headed to the clinic. It's 8:30 in the morning. What I usually do is listen to the Newsworthy every day. They do 10-minute segments on the day before. It's actually a creator on podcast, and it's like pretty unbiased. It doesn't go left or right, so I really like this. Erica Mandy, shout out to her, but she's great. So I usually listen to this every morning on the way into work. Hey guys, so it's about 10 o'clock in the morning and we've seen a few patients in the clinic. So what's a typical clinic day like for me? What I do is I see a mixture of new patients, follow-ups, preoperative patients, and post-op patients. So a new patient is a patient who comes in with a neck complaint or a back complaint, and I basically have to diagnose them by first taking a history, ask them when the pain started, how it started, what the pain feels like, and then secondly doing a physical examination. These are both very important parts of diagnosing a patient's condition. And then afterwards I'll usually recommend some type of imaging like an MRI or an X-ray, and then also start some treatment like medications or physical therapy. And so that patient then turns into a follow-up where they come back, and today I'll see some patients back and they'll be here with an MRI that I'll look over and I'll make an additional diagnosis, or we'll see how they did with their physical therapy or their injection. Then if those patients don't get any better, then they turn into a preoperative visit where they may need surgery. And so I talk to them about surgery, the risks and benefits of it, how the surgery will be performed. And then those patients may have surgery, and then they turn into a postoperative visit where they come back and I examine their wound, I see how their symptoms resolved or if they're having any issues. And that's the combination of patients that I see in a typical clinic day. I'm also keeping my eye closely out on wait time here, right? So part of what I'm concerned about is also patient experience. So I don't want patients to come to my office and wait 2 hours to see Dr. Choi. So I have to kind of move through my schedule. You can see here there's a combination of new patients, follow-ups, post-ops, all in my schedule like I discussed earlier. And I really have to try to move through my schedule. And there's different techniques that you can employ to try to make sure that each patient feels like they have had adequate time. And I want to give them as much time as possible, but at the same time, I've got to stay on schedule. So I keep a close eye on the wait time. A 32-year-old male presents with chief complaint of left lower extremity radiculopathy radiating down into his left buttock, posterior thigh, into his calf. Pain started approximately. So we just made it through our morning clinic. We are now in the diner across the street, having some lunch, just recharging, getting a mental reset before we go back into clinic. So one of the thoughts that I had this morning as I was going through my clinic patients is that being a surgeon, you have a lot of highs. There's a lot of great things about it. It's almost instant gratification. So you have patients coming back, they've improved, you've operated on them, you've intervened, and their back pain's gone, their sciatica's gone, and they love you, and you're basically like the hero of the story, right? And so those are the highs of being a surgeon, but you also have to navigate the lows, which is some patients are not doing as well. You know, they have surgery and their pain improved, but it comes back, or they might have an infection. And so these are some of the lows of being a surgeon, and then you typically get very concerned. Your patients are like your family. If they're not progressing the way you want, I get worried about it. And so the trick is you really got to try to give every patient 100%. So even if you had a patient who had a complication, the next patient you've got to bounce back and really give them your 100%. To really be, I think, successful as a surgeon, you have to always try to maintain that positive mentality and give every patient 100%. So we're halfway through our afternoon clinic. We gotta finish strong, so we're gonna go for the round 2 of the coffee. You get the K-cups. All right, so today's a pretty interesting day. We saw a variety of spine conditions and some bread and butter, very routine things. So one of the most common conditions someone comes to see me as a spine specialist is just primary back pain. They were lifting a heavy box, and all of a sudden they felt a twinge in their back, and they have terrible back pain for the last 2 weeks, and their primary care doctor refers them to a spine specialist. And so 90% of Americans will actually experience back pain at some point in their lives, so it's very common. And the good news is that most patients don't need surgery. They don't need any type of injections or interventions. Just waiting it out with some physical therapy and medications is usually the way to go, and 90% of those patients will do fine without any intervention. Now, I see something as benign and as kind of not urgent as that. And the other end of the spectrum today that I see is someone with a broken neck who's coming in with a collar. They were seen in the ER, they fell and they hit their head. We see that sometimes in the geriatric population. And this patient had a fractured C2, a Dens fracture, where they were fractured right here. And this is a very sensitive area because the spinal cord runs through that area. And also this bone is notorious for not healing well. And so we have to watch this patient carefully and take x-rays. We call serial x-rays, one x-ray at a time every couple weeks to make sure that the fracture is not moving. Because if you move this fracture, it's in an area where it can cause a serious spinal cord injury. So we saw something as serious as that. So the great thing about spine is that you can have pretty common things that resolve well, but you also have to be on your toes to make sure that you don't miss a serious injury as well. So the type of surgeries that I typically perform can be divided into 2 major categories. So the first are decompression surgeries, and the second are fusion surgeries. So what is a decompression surgery? Decompression surgery is like a microdiscectomy. You hear about spine surgeons performing discectomy where someone has a herniated disc, and the herniated disc is actually pinching one of these nerves, and as it pinches the nerve, it causes sciatica going down the leg. And when I go in, I use a little microscope and I create a small incision, and I basically free up the nerve, and I take that disc out that's pinching the nerve, and that's called a decompressive surgery. We also perform laminectomies, which is where I remove a roof of bone here, and that decompresses nerves that are being pinched, and that's another type of decompressive surgery. Now, the second type of surgery that I perform is a fusion surgery. A fusion surgery is where we usually put screws and rods, kind of like this, and sometimes we take bone graft that we harvest from the patient, and the goal of a fusion surgery is to take 2 segments of spine bones, or the vertebral bones, and basically stabilize them so they're not moving or unstable. And you can do that using screws and rods and putting bone graft and achieving a fusion. You do that in the lumbar spine, in the low back, and you can also do that in the cervical spine, where we perform a surgery called an ACDF, or an anterior cervical discectomy and fusion. The discectomy portion is removing the disc in between the bones, and then we put an implant that looks similar to this, and we do that all under a microscope and put screws and secure that implant into the neck as well, and that ultimately will stabilize one segment of the neck to achieve a fusion. All right, guys, it's 5 o'clock, done with the day. I do have to say by around 5 o'clock, my mind is pretty wiped. I'm pretty tired. And the reason being, clinic it seems easy. You're walking in, you're just going into the room, you're seeing a patient, so looking at charts, but really it's not like that. You're really expending a lot of mental energy per patient because you're looking at the chart, trying to make sure you're being detail oriented. You're looking at all their images, making sure you're not missing a single important cut of an MRI or whatnot. And you really want to make an accurate diagnosis for each of these patients. So, like I say on my Instagram, this was a tiring day, but it was really a great day. Hey guys, so we're done with the day. I just wanted to share with you a few gems, a few pieces of advice from my experience getting to become a surgeon. The first thing I want to talk about is some bad advice I've heard out there. And I think a lot of the bad advice I see is actually sometimes on social media. Medicine is often over romanticized on social media. You see the glamorous white coat photos, the scrub photos, everything's good. And we all know, everyone who's been through the trenches knows that's not the case. A lot of it is grinding to become a good scientist, right? So why do we take these pre-medical classes that maybe you have no interest in, organic chemistry, statistics? It's because you're learning how to analyze data so we can discover the truth to tell our patients about what treatments work and what don't. And that's why you have to take these difficult courses. Another thing is when you're in training and you're a resident, you're going to be working long hours in the hospital because you're going to have to be dedicated to your patients, and you're going to miss time with your family. If you have kids, you may not see them. These are not things that are necessarily reflected on social media. You just don't know where someone is on their journey. So if you see a resident posting, you don't know, what they've been through. You don't know if a doctor's at the end of their journey. You don't know if a pre-medical student who's posting about their beautiful study setup is actually going to get into medical school, right? So, when it comes down to it, what I would say is that use your heart and also your judgment, your good judgment to make decisions for yourself. Not all advice is good advice. You're the one who knows yourself the best. So take any advice that you get, kind of rethink it in your perspective. If it works for you, then fine. That's what I have to say about bad advice out there. Another piece of advice that I would give to any aspiring surgeons or orthopedic surgeons, something I guess I wish maybe I would have heard when I was in the training process, is that when you're training and you're in this journey, you always have to imagine yourself 10 years in the future. And what I mean by that is you really should take a forward posture to your training experience, because what you're doing at that time is not what you're going to be doing as a surgeon, right? So you might be a third-year medical student and you're on your surgery rotation and you're getting your vitals and you're running around and you're getting bandages, and what you're doing seems completely unrelated to being a surgeon. What my recommendation would be is that you have to imagine what it would feel one day to have someone hand you the scalpel and say, Dr. Choi, what are your recommendations for surgery? And then, actually helping someone with your hands and helping them feel better, take away their pain. You have to imagine that, because it's not going to actually happen until you're an attending surgeon. You get bits and pieces of it, and you get more and more of it as you're a resident. You get to taste it more, but it doesn't really hit you full force until you're an actual attending with your own patients. And to be honest, it feels awesome. It feels exactly the way that I imagined it would feel. The feeling of gratitude that your patients have for what you can do with your own hands is just amazing, guys. So stick on that journey, but really just always imagine what it's going to feel like in 10 years. Hey guys, so I'm pretty active on social media, so if you wanted to reach out to me or see any of my posts, I'm on YouTube at Dr. Daniel E. Choi. I'm also on Instagram at SpineDocNY, and also on Twitter at Dr. Dan Choi. Thanks for watching, guys, and I'll see you on the next video.